All right, so we're done with the obsolete modes of ventilation. Any questions on those? Right? These we consider them obsolete. Now we're gonna start working on pressure support, volume control, and pressure control. We'll do pressure support today, and then volume control, pressure control later. So for pressure support, this is the simplest mode of ventilation. I would call it, if you really more people are familiar with BiPAP now is more familiar than vents. So unfortunately, I have to tell people that this is the BiPAP of the vent. This is like the BiPAP of the vent, exactly. So, so the set parameters are pressure support, PEEP, and FiO2. Nothing else. You control nothing else. You just give a little bit of PEEP, a little bit of FiO2, and then when the patient takes a breath, give him pressure support for it. But the patient determines everything else. So the dependent parameters, Untitled volume, mean airway pressure, respiratory rate, etc. The waveform are very, it looks like this. So pressure support by itself is a misnomer. It's supposed to be called CPAP / pressure support. That's the mode. In fact, that's the mode that we have in our vents here. It's called CPAP / pressure support. It's a long name. Some people call it CPAP. Can I put the patient on CPAP? Yeah, I know what you mean, right? Because nobody will put CPAP alone. CPAP is like this. This continuous positive airway pressure. That's CPAP. It's like PEEP. And pressure support obviously is like this. So it is a pressure support carried on CPAP. So that's the first thing. That's a misnomer. The second thing is that this is very characteristic in two aspects. If I don't tell you nothing and I tell you what this mode of ventilation is, you're gonna have to tell me that's pressure support. Why? Two things. Number one, each breath is preceded by an effort to breathe. So if you see something like this, that's impossible that this is pressure support. Also, the breath is short. There's minimal control over the time of the breath. The patient finishes the breath as opposed to this one, for example, right? So the breath is short. This mode of ventilation is gonna come back, and probably is coming back as we speak as a strong mode of ventilation that may actually take over, or at least partially take over the bellows, you know, the volume control that everybody likes to. So it's gonna come out. It's gonna come back in a mode of ventilation called AVAPS. And AVAPS is one of the advanced modes of ventilation. So when we talk 3 obsolete, 3 current, and 3 advanced. AVAPS, I'm just cheating. I'm going to the last lecture of the vent, which is the advanced modes of ventilation. But it's the same thing as pressure support, and that's how pressure support is probably gonna come back. I mean, pressure support is here for us, right? But the problem is not as famous or as used as frequent as volume control. But once you start having something like AVAPS, you might actually start seeing more pressure support. So AVAPS is called adjustable volume assured pressure support. So it's a pressure support, but it's volume assured, right? This is obviously a very ominous name, so that's why people don't like it in the ICU. But what it does is that it changes this a little bit. It makes this a tidal volume, and this is PEEP, and this is FiO2. So what it does, it tells you, instead of you ordering a pressure support, order a tidal volume. And let's say you want 500 tidal volume. So the machine, what it does, it will give you a 500 tidal volume using pressure support. So we'll go like this, and we'll say, okay, the area under the curve is 500. Okay, that requires 25 of pressure support. So all of the subsequent breath will be 25. Right, pressure support. And then you're getting better, for example, then the machine will go down on the pressure support until 7, for example, pressure support will give you also 500 tidal volume. Right? And then you're ready to be extubated. So it can wean itself. You just set it and forget it. You don't need intensives. And if you can invent an arm that goes in and pull the endotracheal tube, then you're golden. You don't need anybody. But see, that's the mode of ventilation. It's actually more comfortable, even more comfortable than this for the patients, and the patients will take it and require much less sedation. The other thing is that will bring these modes back are the group of studies that started in 2006. I repeated this study multiple times. It's a landmark study that was done on rats, that they took rats and ventilated them for 2 days without any paralytics, and after 2 days they looked at their diaphragm and they found the diaphragm is necrosed already, or some of it is necrosed, meaning that the diaphragm doesn't like to be taken over. If you take over controlled modes of ventilation, the patient gets weak. So that's why these modes of ventilation are coming stronger now, because they want to see the patient walking with an endotracheal tube. And you're not going to walk somebody with an endotracheal tube on volume control. That'd be like suicide. You know, you don't want to do it because he's not going to tolerate it. So you give him the simplest mode of ventilation, either this or that, right? Okay, so for this mode of ventilation, if you notice here, there's no respiratory rate for the set parameter, so it's dangerous, right? What's going to happen if the patient stops breathing? So of course, we'll have to they have to do the apnea settings. So there is something called, for safety, it's called the apnea settings. And that means that if you stop breathing for 20 seconds, the machine will give you 1 minute of VCV or AC, volume control, 1 minute. Usually 14 breaths per minute times 500 type of volume. And then after the 1 minute, it will put you back in pressure support again. And see, if you don't breathe again for 20 seconds, it will do it again. That's for safety. So that's great, unless you're trying to do that for SBT, and it happens so frequently, and it's very difficult to convince respiratory therapists otherwise. Like I think I made maybe a 50% success in this hospital where I live, right? But still, there is a lot of culture that comes behind this, and they can't tolerate patients who are apneic. And I'm sure each one of us had heard this phenomenon where somebody comes in and say, the patient failed the SBT. And you don't ask how the patient failed the SBT, and you move on to the next patient. But if you ask, they'll tell you, oh, he failed because of apnea. Apnea is not a failure of the SBT, it's a failure of the respiratory therapist, or the nurse, or both, or us, or the doctors too, because you didn't wean sedation or whatever. So if somebody is apneic on SBT, number one, that's a great indication for me that this patient is going to be extubated. You know why? Because he doesn't want to breathe fast. He's not tachypnic. He's like relaxed, too relaxed actually, right? That's number one. Number two, this actually the causes of being apneic on SBT. Either you're too sedated, or you're too ventilated. You're over ventilated. Okay. So how does this happen? So basically, you have to think about it in terms of pH. So let's say I walk in this room with a pH of 7.4 and 40, and I'm giving a lecture now. So I keep talking, and unconsciously, my respiratory center is going to say, stop talking, take a breath, and continue to talk. I'm not going to even feel it, right? But if I give myself a little bit of morphine or fentanyl or Versed that we give our patients, right, before I come to the lecture, I might actually, my respiratory center will be a little bit more numb, and I may actually be able to tolerate up to 50. The respiratory center is not going to tell me anything until I reach to 50 of CO2, which is probably 732. When I reach 732, the respirator says, enough, take a breath, continue. That's most of our patients, right? That's what I thought. Most of our patients is here. 728. So I keep talking until I reach here. If I give myself morphine, I reach here. Right? I'll be able to reach here, and then. So, in order to reach from 40 to 55, how much does your PCO2 rises by 1 minute of apnea? How much? So that's 6. Yeah. So 6 in the first minute, and 3 in all the subsequent minutes. Right? That's why when we do the apnea test on people, we do it for 10 minutes, because it's actually 6 minutes and then 3. That'll give you about 29 or so of elevation. That's which is higher than the 20 required to do the apnea test. So anyway, so every minute I'm gonna raise it only by 6. So I need about 3 minutes or so to reach here. But in 20 seconds, the vent is gonna say, he is not breathing. I only raised this to 42 or something. This one is gonna say he's not breathing. Let's give him a 1 minute of AC. We'll wash out the two that he made, and then we'll put him back again at the same level that he started with. So he does it again. So it becomes a vicious circle. So he'll be looking at you like this, but he's not breathing. And you talk to him, you have pain? No. And he's not breathing. So everybody's like, it's a stroke. What is a stroke? Like, like a stroke just hit the respiratory center only and nothing else? It's impossible. So this is what happened here, and people get anxious and they stop and that's very unfortunate. What you do, you go with them in the room and you keep resetting the alarm. The alarm happens every 20 seconds. It happens before they give the breath, or the machine gives the breath. So reset 10 times or something, and then the patient will breathe. Okay? Yeah, it's fine. 10 times, it's still oxygenating. They're getting oxygen. So they're gonna build up CO2 until they breathe. Or you can squeeze the vent tubing if you want. Just one of our respiratory therapists here just like to squeeze. It just likes to fold the vent. So keep squeezing the vent tubing, and the vent thinks that the patient is breathing. Or you can change the apnea settings to 60 seconds. That's the least preferred, because that means the patient will remain. I mean, this will remain for the next patient. Will be the default for the next patient. So, whatever you do, but just let the patient breathe. I can make anybody breathe as long as they're awake. Okay, so that's your apnea settings here. So let me go on a tangent a little bit. I'm going to ask you, what is the ideal pH? So as we know, when we ventilate patients, we ventilate them to the pH. We want to ventilate. That's our goal. It's not the PCO2, right? If you ventilate a COPD based on a PCO2, then you're going to make a mistake. You're going to be very alkalotic, and it cause a problem, right? So so I don't care what the PCO2 would be. 40 could be 100. What's the ideal pH? Professor Baldwin, what's the...
We're supposed to say 7.4.
Supposed to say, like, yeah, somebody's telling you that you have to say something?
Yeah.
So it's actually 7.3, or between 7.3 and 7.4, but definitely less than 7.4 in an ABG. The reason is, this one obviously is too low, right? That's like acidotic. We don't want to play with it, with acidosis. These two here are commonly mistakenly left, and people don't look at it. 7.46. Okay, great. He's breathing. He's breathing great. Actually, we don't have any problem with the vent. People take it that way, but actually, you will cause a problem, because these are very alkalotic, which means that the kidneys in about 1 day or so. It takes time, but about 1 day or so is going to say, we're alkalotic here. I have to lose bicarb. So the kidney starts to lose bicarb, and you end up with bicarb of 18, for example. And then show me how we're going to extubate this patient now. Because we decreased the bicarb, we want to take he was breathing good yesterday, but today he's breathing in the 30s. I don't know why. Because the kidney lost the bicarb. And then this one is not bad. The 7.4 is not bad, but of course you have to think about it in these terms. That the patient has to go every SBT, will wait for a long time for him to breathe. So it'll be not practical. And also, I want the patient to be on their toes all the time, always breathing above the vent, always breathing above the vent. If he's 7.4, he might not breathe above the vent, right? So we always have to maintain the 7.3.5. And that is it.